Hello, my name is Mariana, and I am a psychology student at Capilano University in British Columbia. Today I'm going to present my final assignment, which is a discussion about two correlated scientific articles that I researched and I'm interested about, which is the mindfulness training programs for workplace applications. This is regarding my PSY 101 course that is lectured by Pyong Lee. Two studies reviewed in this presentation are the comparison of mindfulness training and acceptance and commitment therapy in workplace settings and a workplace acceptance and commitment therapy intervention for improving healthcare staff psychological distress. The first study uses 2 decades of previous research supporting the utility of mindfulness interventions in the healthcare workplace to advocate about their potential to reduce perceived distress, psychological distress, and improving mental health. The two programs analyzed are mindfulness training and acceptance commitment therapy interventions to assess if these applications can enhance job performance. The second article discusses about the evidence and the research showing that ACT interventions are helpful and effective for improving mental health, psychological distress, and burnout in the healthcare professionals, also aiming to investigate if this intervention can also impact the safety of the staff. We will start with the first article, which is a comparison of mindfulness training and acceptance and commitment therapy in a workplace. This study aims to examine and compare the longitudinal effects, meaning the long-term effects, of applications of mindfulness training and acceptance commitment therapy, and test the following: stress reduction, improving sleep quality, cultivating mindfulness, increasing alignment of behavior with personal values, example, value-based actions, and later on we will be talking about this and the connection with the values, a person's values, their behaviors, and how the ACT helps to improve that and align that, and helping employees to overcome internal barriers to effectiveness at work. For example, reducing work limitations. The issues that were researched in this first article question if the MT and ACT are equally effective for reducing perceived distress and improving sleep health. And can MT and ACT programs enhance work performance or productivity in a healthcare worksite? The research design for this article includes experimental, pre-intervention and post-intervention measurements, mindfulness intervention, mindfulness training and acceptance commitment therapy, healthcare, workplace, stress management, sleep quality, and performance improvement. 3 groups were randomized to one of the 3 conditions: the MT group, the ACT group, or the waiting list group, which is the controlled group. All interested participants had to complete time 1 pre-intervention measurements. So before even participating in the study, the participants that were interested in this research, they would have to complete a questionnaire, which is time 1, so the researchers would know a little bit about that participant. All the participants worked for a large healthcare organization in London, UK, recruiting. An email was sent out to about 5,000 employees of this host healthcare organization, and the subject of the email was strengthens your well-being and personal resilience. This flyer was sent out to everyone. The exclusion criteria was to be employed by the host organization and being age 18 years or plus. The results from this invitation was that 303 employees sent an email back to obtain information about the research. 63 candidates withdraw, and 199 completed the time 1 pre-intervention measures. From these 199, they were randomized, put into groups. One of the 3 groups. Empty group had 63 people, ACT group 67, and the waiting list group or controlled group had 69. An interesting fact is that most of the participants were female, 77%, which is a great number, and the mean age was 42 years. That ranged from 21 years old candidates to 62. Job roles included nursing, physicians, people that worked on healthcare related assistance, department managers, psychotherapists, admin, clerk, and etc. The schedule. There were 4 sessions in total, and they were to be done across 6 months period total. The first 3 sections occurred in consecutive weeks, with the 4th session occurring 6 weeks after session 3. Each session lasted 2 hours and were offered during work hours or early evenings. Participants received the same battery of self-report measures at 1.5 months or 6 weeks intervals in spanning the 6 month evaluation period. 5 measurement occasions happened in total. The 2 programs offered different things. Obviously, the waiting list control program did not offer the mindfulness training or based programs. The mindfulness training program offered sessions that were organized around a theme and contained at least 2 guided mindfulness exercises, which were approximately 30 minutes duration. So a long mindfulness session. The MT program was also based on the mindfulness-based stress reduction program, the MBSR. Participants were provided with a booklet including information on each session's theme, handouts, and audio material for home practice. Participants were encouraged to practice daily meditation, including both formal and informal practices. Therefore, they had a very strong focus on the meditation side. And this meditation was also sent, that was an exercise not only during the sessions, but also at home for homework. ACT program offered training in 2 interrelated skills, mindfulness and values-based action. The stated purpose was to learn how to use personal values as a guide to daily behavior. So now we do have a different program that focus on the mindfulness exercises, but also on the value-based action that would influence someone's behavior. Each session was organized around a theme, included at least 1 guided mindfulness practice, which approximately take 10 minutes each, a values exercise, and presentation of ACT metaphor. Participants were provided with a booklet conveying the session theme, handouts for the exercises, and audio materials. Participants were encouraged to practice meditation at least 3 times per week, along with value-based action exercises. So we do see difference here. Like obviously the MT requires requests or encourages the participants to do mindfulness meditation on a daily basis, whereas the ACT program asks the candidates to do meditation at least 3 times per week. And these meditation times are also different. The MT program encourages participants to do meditation that are 3 times longer than the ACT. So they do focus more on that. The ACT focus a little bit of the practically of the mindfulness as well. This is my view. I feel like when the participants also have exercises that are value-based, I'm also reflecting about myself while I do meditation, and I need to put in practice what are the behaviors that I can do at work, for instance, to that are going to be aligned with my values. So that was the main difference. How long the participants were doing meditation in the sections and at home, and the exercises that were value-based exercised. The measures utilized for the mindfulness training comparison with the ACT program was perceived distress scale, the PSY, in which asks the respondents to reflect on life demands, sense of overload, and uncontrollability over the past months. Like, for example, a common question would be, in the last month, how often have you felt that you were unable to control the important things in your life? And many other questions. The responses were captured on 5-point response scale, ranging from 0, meaning never, to 4, meaning very often. And scores could range from 0, which means lowest score, to 16, which is the highest score. A high score indicates greater perceived stress. Work limitations questionnaire short form, which is the WLKSF, in which the candidates were assessed with the WLK short form, which measures on-the-job impact of health and emotional difficulties on specific job demands, including evaluating difficulties with time management and scheduling, mental interpersonal demands, assessing cognitively demanding tasks and work-related social interactions, and output demands, which assesses the work productivity. So this questionnaire was more focused on work-related limitations. Sleep quality was also assessed by using the 4-item sleep disturbance scale from the Physical Health Questionnaire, PHQ. The scale captures different aspects of sleep disturbance, including difficulties to fall asleep, premature awakening, and whether sleep has been peaceful or undisturbed. Participants rated their sleep over the past 2 weeks on a scale ranging from 1, not at all, to 7, all of the time. Items were reversed, meaning scored so that the high score indicated better sleep, so different than the perceived stress scale. Another measure utilized was the 5-facet mindfulness questionnaire, which is also called FFMQ facet. In total, there are 23 items, but for this particular research, they used three items from the FMMQ, which is the acting with awareness, not judging, and non-reactivity. Acting with awareness facet captures the attentiveness during present moment activities. The non-judging subscale captures the degree to which a person makes self-critics or critics evaluations about the presence of unwanted thoughts or feelings, and the non-reactivity to inner experience captures the ability to step back from difficult thought, feelings, and sensations without necessarily reacting upon them. The last questionnaire and measurement item was the valuing questionnaire, the VQ. The VQ originally has 8 items, but for this particular research, they utilized 6 items of the original questionnaire. 3 progress and 3 obstacles items were combined to create the 6-item measure of values-based action. Participants were asked to respond over the past week on a scale that ranged from 0, not at all true, to 6, completely true. Now we are going to analyze the results from the first article, in which they had 5 hypotheses. The first hypothesis was regards to the perceived distress, in which it was predicted that both MT and ACT, compared to the waiting list control group, would reduce employees' perceived distress over a 6-month period. In here, we can see that the ACT group, which is the blue line, and the MT group, which is the green line, they had a significant decrease on perceived distress that was ranging from 9 to 11.5. They all kind of started on a high level, and they end up on a very low level here after the program. These results also show that over time, the ACT and MT programs are even better. Meaning that they have compounding effect over time. Another interesting fact was that even the controlled group that was not exposed to the ACT or MT programs, they also somewhat had reduced in stress, maybe because they were participating on the research. This was not clear when I read the article, but just by participating, just by showing interest in mindfulness programs, it seems like that was also beneficial over time. But the significant results, the significant positive effects of mindfulness training were definitely showed here, and that directly impact the perceived distress for the healthcare practitioners. The next result was the hypothesis of the sleep quality. In here, we do have the score showing the reverse results from the previous hypothesis, meaning that the higher the score here, the better the sleep quality over time. Another interesting fact that I did not mention on the previous slide, but I would like to mention now, is that the 1 to 5 here represent the 5 measures that were taken over a 6-month period time. Just wanted to clarify that. But in here, it's clear, the hypothesis was that it was predicted that both MT and ACT would improve employees' sleep quality compared to the control group. As we can see here, this is totally true. Again, it seems like the MT on the previous slide was slightly better than the MT results for the perceived distress, but here for the sleep quality, it seems like the MT has a better and continuous result over the ACT, and obviously both were better than the waiting list control group. There was absolutely no change on those. Their sleep quality stayed the same. The ACT and the MT are definitely beneficial, but again, the MT seemed to be a little bit, seems to provide a better positive effect on the candidates over the ACT in both hypothesis 1 and 2. Hypothesis 3 was related to mindfulness. Was predicted that mindfulness would increase in both MT and ACT conditions related to the working group. As expected, the results for both MT and ACT programs indicated a significant linear growth effect of mindfulness compared to the controlled group. However, when comparisons were done between MT and ACT, there was no significant results when it comes to mindfulness. An interesting fact is that ACT program had 3 times less mindfulness exercises during the sessions, and almost half of the practices that were asked to be done for homework. And still, the mindfulness awareness that was created for both were almost the same. The fourth hypothesis is related to the work limitations. It was predicted that the ACT would be the superior approach for reducing work limitations when compared to both MT and to the waiting list control condition. It was shown that there is no significant effect when comparing ACT and the MT and the control group, or when comparing MT program against MCT program when it comes to improving the work limitations. After I was reading the discussion of the article, I also realized that this was due to the lack of measures, like say work performance measures, and the lack of information that it was provided during this time. It gets really difficult to measure the work performance when you have so many different types of health practitioners working in such a big hospital, meaning that to analyze the work performance of a physician and a nurse and a clerk and an admin person, like they would require different measures to analyze and assess their performance, and to see if the mindfulness programs and the ACT programs were actually helping people to perform better. So it requires a lot more time, and it requires a lot more measurements to make a better conclusion. The last hypothesis was the value-based action, and they were expected a superior increase in values-based action for the ACT condition when compared to MT and the waiting list control group. Consistent with the hypothesis, the ACT intervention presented a significant growth in value-based action over time against the control group and MT interventions. No significant growth effect was presented for the other comparisons. Last but not least, the conclusion of the comparison of mindfulness training and acceptance and commitment therapy in the workplace setting in a healthcare facility is that overall the findings indicated that MT and ACT can be viewed as alternative approaches that deliver durable improvements in stress-related and well-being outcomes by successfully cultivating mindfulness processes. We saw that it improves the sleep quality, it reduces the perceived distress amongst the people. It also increases the mindfulness and also aligns the employees, the staff, value-based thoughts and feelings with their behaviors at work. So the data shows, it has been showing for the last 2 decades, and this is a study from 2024, so very recent study, and keeps proving that mindfulness processes helps individuals in their mental health, well-being, and etc. There is not enough data to analyze if mindfulness processes would also improve the work performance of the staff, and this is the direction to the future research. The lack of impact on work limitations and insufficient data indicates that this study should incline and be assessed with the already mixed body of evidence surrounding job performance outcomes. I do believe that it's going to require a lot more time, and maybe selected job titles and activities, they should be analyzed differently, because obviously the level of stress of a physician or a nurse that works overtime is way higher than a clerk that works from Monday to Friday. And for that reason, I do believe that they will have to separate the job performance of these two and do more research on them. And I also believe that once there is research proving that the work performance improves due to the mindfulness processes, I think it will be finally the companies, the organizations will start to invest a lot of financial resources to help spread the mindfulness training across the board. The next article talks about a workplace acceptance and commitment therapy intervention for improving healthcare staff psychological distress. So again, very similar to the previous one, but this one focused only on the ACT program, which is also mindfulness based. And this is also focused on the primary outcome is to focus on psychological distress of healthcare staff. This study aims to investigate if a shorter version of the ACT intervention is effective for improving psychological distress and burnout in healthcare professionals, and if the intervention has a direct or indirect impact on perceived patients' safety. So basically, we're going to analyze the primary outcome, which is reduction in psychological distress, and the secondary outcomes, which is reduction in burnout and work-related worry, reduction in ruminating, improvement in psychological flexibility through a combination of processes, which includes mindfulness, cognitive diffusion, use of metaphor, personal values clarification, and values-based behavior activation, and improvement in perceived patient safety. Another important difference from the previous one that is interesting to analyze here, and I wanted to bring this to your attention, is the fact that the previous study wanted to see the positive effects of mindfulness training, including MT and ACT, mindfulness programs, including MT and ACT, in a long span, 6 months. In this one here, they want to see a mindfulness program-based ACT intervention in a short term, in a month, 4 weeks in total. So that's another very interesting fact, and one of the reasons why I wanted to bring this article against the first one and compare them to see, we already saw that the long term is efficient. Now, can the short term be efficient? The research issue included the high levels of burnout and distress are long-standing concern in the healthcare workplace that may have implications on the following: staff mental well-being, mental health, quality of patient care, reduced perceptions of patient safety, and heightened risk of medical error. The participants involved in this research worked for healthcare organization in Yorkshire and Humberside in England. The research design was experimental. There was a mid-intervention, post-intervention, and follow-up, mindfulness-based worksite training, intervention, acceptance, commitment therapy, healthcare workplace stress management, burnout, and patient safety. 2 groups were randomized to one of the 2 conditions, either ACT experimental group or waiting list control group. The recruiting method was participant information sheet and a consent form was sent over by email. The exclusion criteria was being currently employed by the host organization. A total of 146 candidates returned the consent form because they were interested, but 98 were included in the study. 52 were selected to be in the experimental group and 45 waiting list group. Again, same scenario as the previous article in study. Most participants were female, but this was the majority of the participants. The previous research showed 77% of the participants out of 199 in total participants. In this particular article. From 98 total participants, 92.7 were female, and the mean age was almost 43 years old, very similar to the previous one. Job roles included nursing, mental health professionals, managers, admin, consultants, dietitians, technicians, and other mental health related services. Schedule: 4 sessions delivered in 4 consecutive weeks, very short term. The participants were assessed 4 weeks before the intervention, which was the pre-assessment, pre-intervention. Then between week 1 to 3, they had another assessment, and after session 2, so it would be between session 2 and 3, really, which is the mid-intervention, and after 4 weeks of intervention, which is the post-intervention. And 14 weeks after the start of the intervention which is the follow-up intervention. So basically 4 weeks before, once the program starts, half of the way, basically, and then 4 weeks from the intervention started, which is at the very last session, and then 14 weeks after the start of the intervention, basically 2 months and a half after the last session, there is the follow-up intervention. Each session lasted 2 hours and were offered after work hours from 7 to 9 p.m. in venues outside the organization. Here, I would like to also point out two differences from the previous article that are very interesting to me. The previous article did the sessions during work hours or early evenings, like right after work hours, maybe around 4 and 5. This intervention was done completely outside of work hours, which maybe impacted on the number of female participants, that was very much higher here. Maybe that was one of the reasons why, because I feel like when you do things outside of work hours, you basically need to put more effort in being diligent and making sure that you attend the sessions. And I feel like females are naturally more interested in mindfulness. This is my personal opinion. But when we make it easier for the male candidates to participate, that could probably enhance their attendance as well. The other thing I would like to mention is that on the previous article, there was no follow-up intervention, which I believe it would be very interesting to have. So we would have a 6 months period and maybe a 2.5 months follow-up after the 6 months point would be interesting for the first article. They did not have that. The ACT program offered a structural combination of mindfulness and value-based work. The first session, participants were introduced to both mindfulness and values psychoeducational to help them become familiar with psychological flexibility processes. There were 4 exercises given: the raising exercise, the body and breath meditation, the values card sort exercise, which involved reflection on various thoughts and feelings that interfere with personality value action, and the passenger on the bus metaphor to help participants understand their psychological barriers and maybe put into perception others' perceptions as well. The second session of 4 sessions, the participants were invited for the first time to the psychological flexibility component of the cognitive dysfunction. And the session started with the body and breath meditation, introduction to the distinction between thinking and sensing modes of mind, participants' retrospective exercise based on a simplified version of the ACT matrix, in which participants were invited to notice the barriers that block them from the qualities they wanted to express the most, and to create the ACT matrix focusing on their values. And to conclude, participants were invited to an adapted version of the passenger on the bus metaphor, presented in session 1, but with the aim of cultivating cognitive diffusion. The cognitive diffusion in here, it's highly related to the psychological flexibility, meaning that when you have the cognitive diffusion, you would be able to perceive your thoughts or perceive your judgment about certain situation because of your previous experiences, your cultural, educational, your family background, all those things, they come to play when you do perceive something or someone. And when you do the passenger on the bus metaphor, but you put yourself in the position of another person, now you have this exercise that obligates you to see the same situation from someone else's eyes. And that helps us to have the psychological flexibility that the ACT program wants us to have, is when you are able to perceive another perception of the same situation with a completely different eyes. Meaning, the way I see a certain situation is not necessarily the only truth, is not necessarily the only right way of perceiving it, and that's what the ACT wants to teach us here, is the psychological flexibility. Another interesting aspect of the second section is when the participants are presented to the ACT matrix, in which in here the focus is to the values that someone has, and what are the qualities and behaviors that one needs to express in order to meet those values. And the focus here is the behaviors at the workplace that are aligned with someone's values. The third section, which is the following week, participants were invited to the psychological flexibility component of acceptance. The session would start as well with mindfulness exercises, focusing on breathing, bringing attention to the body sensations, linking between the notice exercise with the physicalizing exercise, the trainer would also read the Rumi guest house poem and request the participants to repeat the ACT matrix with different life areas. And the conclusion of the 3 session would be another mindfulness exercise. The very last session of the 4 weeks is the overall aim of bringing together and refresh all psychological skills learned in the previous sessions. The session would be open with a mindfulness exercise and then a retrospect noticing exercise. A different version of the value-based construction exercise was repeated, and the main focus of this last session was to invite the participants to participate in a role play by acting out the passengers on the bus metaphor to help participants relate to different thoughts and emotions. So again, we would go back to this idea of exercising mindfulness and then exercising our focus to the sensations, to the physical sensations, instead of only focusing in our thoughts, as well as focusing on our values-based the exercise of constructing our value base, and how can we utilize or express in attitudes and behaviors ways that can align us and make us closer to our goals to live and work based on our values. So it's another interesting part of this is that we do have the passengers on the bus metaphor that keeps coming back, and this is also an interesting way of perceiving different ways of seeing the same situation. We do have the Rumi poem that also makes us reflect on the physical aspect of one's person and what they're going through and how different that is for us, and basically teaching us how to in a humble way, how to accept different perceptions and different situations in a way that maybe make us observe the physical arousal, and when that happens, and observe our thoughts, and when that happens, and observe that all that happens because of the way we are and the way our brain's wired, and that could be different for someone else. And then to step back and take some time to observe all of that and understand, now how can I react, not based on what I'm feeling physically or what I'm thinking mentally, but based on my values. I think this is the main message here. The outcome measures. We had the general health questionnaire, which is the GHQ 12, that includes 12 items to measure psychological distress, including feeling unhappy, depressed, and constantly under strain. High scores indicate higher levels of psychological distress, with 1 being better than usual and 5 much less than usual. The Likert scoring method was also used, and participants were classified as asymptomatic with number 0, subclinically symptomatic number 1, symptomatic number 2, and highly symptomatic number 3. The Shiram Melamed burnout measure, which is the SMBM, composed of 14 items and 3 subscales that captured 3 core components of the burnout: the emotional exhaustion component of the burnout, the physical component of the burnout, and the cognitive awareness of the burnout. The emotional exhaustion includes the perception of the drying up of one's emotional resources and the feeling that one has nothing to give on a psychological level. This is very common in healthcare practitioners, in which they feel emotionally drained when they work in hospitals. This is a very common type of burnout, the emotional drainage. The physical component of the burnout measures the exhaustion derived from the chronic stress, meaning that they're so tired that they cannot leave their bed to go to work in the morning. The cognitive awareness concerns the difficulties of concentration, when they do have dysfunctions into making sure that they focus in their work. And that could also include problems with worries and ruminations, negative thoughts, and negative thoughts such as I have difficulty in concentration. High scores indicated high levels of burnout. Other outcome measurements include the affective rumination scale and the perseverative cognition scale, both used to access work-related worry and rumination. It thus captures employees' experience with negative affect, which includes intrusive and or annoying thoughts, ruminative thoughts, and about work during non-work time. For example, during evenings and weekends. This scale asks people to describe these different feelings and they may have at work, from 1, very seldom, to never, to at all, and to 5, very often or always, to a great deal. High scores indicated higher levels of worry and rumination. The other measure was the safe practitioner measure, which captures perceptions of organizational and personal patient safety using the following 2 items. In the past 4 weeks, my practice is not as safe as it could be because of work-related factors, conditions. Or, my practice is safe in the past 4 weeks. The scale is rated from 1, strongly disagree, to 5, strongly agree. The other process measures, with particular specialty to these 2 here, were used to investigate the mechanisms of action that ACT intervention may change. The first measure here is the multidimensional experimental avoidance questionnaire. distress endurance subscale, the MEAQDE. This 11-item subscale measures an important aspect of psychological flexibility, one's ability to endure difficult thoughts and feelings in order to complete important activities. Items were rated on a scale that extended from 1 strongly agree to 5 strongly 1 strongly disagree to 5 strongly agree. High scores indicated higher distress endurance. Short form 5-facet mindfulness questionnaire. If you don't remember, we did have the same type of measurement on the first article. They also use this measurement type, which the short scale of the multidimensional 5-facet mindfulness questionnaire. On the previous one that we saw on the first article, we used 5 sub components of the mindfulness. In this one here, is still short, but they used 5 subcomponents of the mindfulness, including observing, describing, acting with awareness, non-judging our experience, and non-reactivity to difficult inner experiences. So in this case, they also included 2 other additional subcomponents, which is observing and describing. In this study, the total score was employed. Higher scores indicated higher levels of mindfulness from 1 to 5. And the scale is rated from 1 strongly disagree to 5 strongly agree. The one thing I would like to point out is that from the 5 subcomponents, the 2 that were added, observing and describing, they're included so that the person that is facing a difficult situation, they do have time to actually analyze the situation. So they first need to observe the situation, and then they need to describe the situation mentally or to themselves. They can leave to a place and describe the situation to themselves and say it. And by doing that, you automatically get from a place of being emotional and impulsive and reactive to a place of passively observing, describing the situation to yourself to see if you really understood the situation correctly, and then going to acting with awareness, making the best decision that you can make aligned with your values, and being non-judgmental and definitely non-reactive. So observing and describing, they are important to being not reactive. And I think adding these 2 subcomponents to the first article would be probably beneficial for the results at the end, because by making sure that you observe and you describe the situation to yourself, you think twice or 3 times, and by doing that, you have higher chances of not being reactive. The less process measurements, they are also related to the ACT program, and there are the value questionnaire that's also, I don't know if you remember, also used for the first article. This 10-item questionnaire assessed people's ability to engage in valuing actions, and items were rated on a scale that extended from 1, not at all true, to 6, completely true. High scores indicated high scores in value-based living from. The other one was the self-compassion scale short form. This is a very interesting one. I've never seen this measurement method before, but it captures the propensity to treat oneself with care and kindness, to accept one's imperfections, and tendency to take a balanced perspective on one's experiences. This is a 12-item self-compassion scale that has 6 subscales: self-kindness, self-judgment, common humanity, isolation, mindfulness, and over-identification. Items were rated on a scale that extended from 1, almost never, to 5, almost always. High scores indicated higher levels of self-compassion. I truly believe that this was an interesting measure that was included in here, and it would be interesting if this was also included on the previous article, because when you do have compassion to yourself, there is higher chances you will have compassion to others. Meaning in a workplace, this is even more interesting to assess, because if I'm really rigid on myself, I would tend to be rigid on others and less compassionate to others. So working on this and using this measure, I do believe that makes it more successful to have positive effects with the mindfulness practice. Finally, we are going to assess the results from the first study. We do have the psychological distress result, which is the primary outcome. This is the main reason why they did this research. And it's clear that the ACT training had a beneficial effect on people's psychological distress in comparison to the controls group. This includes from the baseline to the midpoint to the post-intervention and the follow-up. It's clear here that after they did the GHQ-12 measurement method, it was clear that over time, on the period of 4 months, their stress came from 16 all the way down to around 10, which was the lowest point. And after the follow-up, this was after the last session, which is an important fact here. After the last session, that's when people had the best results with a continuous training, ACT training based on mindfulness based. And after the training was done, their level of stress was back to the midpoint. So these results indicate that it's very important to continue doing the ACT training. It's important to do the mindfulness training exercises and the value-based exercises. The results, even though this is a short-term result, it's clear to me that the results are fantastic, the benefits are fantastic, and the importance of continuing the training is also very important. The secondary outcomes, very interesting as well to see. The burnout is the first one. They also wanted to analyze the work-related worry and rumination and perceived patient safety. The burnout, the results showed that the ACT intervention only led to significant improvements in the cognitive awareness aspect of the burnout, indicating that the most significant decline over time. However, no statistically significant effects of the ACT intervention were found on the physical or emotional subcomponents of the burnout. Interesting to me, my personal opinion is that due to the short term, because this was just a 4 weeks or 1 month, maybe the burnout outcome was not as good as it could be. I believe that in the long term, it would be better. This is maybe it's a future research to be made. I do think that the burnout would drastically have positive effects if this was measured maybe on the long term. Work-related worry and ruminations, no statistically significant effects were found, as well as perceived patient safety. I do strongly believe that this is because of the short term. I would be very interested to see the same study on a 6 months long span. And I'm sure that we would have significant benefits from it. Reliable and clinically significant changes results. This was very interesting as well. We did not see these statistics for the first article, and I would be super interested to see it. At the 4-week post-intervention, 48% of the participants, 25 of the 52, who received the ACT intervention met the criteria for reliable change, with all but one of these changes reaching the threshold for clinical significance, 46.15%. I think this is a huge scientific data that proves that ACT is truly effective. Even though this is self-reported, I also believe that there is some reliability when it comes to healthcare practitioners providing this feedback. At the follow-up intervention, 52% of the participants, even more than the 4-week post-intervention, who received the ACT intervention met the criteria of reliable change with all, but one of these changes reaching the threshold of clinical significance, which is 50%. This is amazing to see. Even after, you can tell. And I think this is definitely due to the psychological reduction of the psychological distress. I think the majority of it. Conclusion. This study showed that the 4-session ACT training program is an effective intervention for improving psychological distress in healthcare practitioners. These findings show that an acceptance-based approach like ACT can improve healthcare practitioners' health and well-being. Mindfulness, values, and self-compassion were found to mediate intervention effectiveness, aiming to reduce staff burnout and ultimately resulting in reduced staff's absenteeism rates. As much as I emphasized on the first article, here we do have the reduction of staff absenteeism rates, and hopefully once the organizations notice that they can have financial benefits from this data, and also if we do have more information in regards to the burnout and the rate of people that gets to take sick leaves or short-term sick leaves, which is one type of absenteeism due to the burnout. I believe that the companies will start really investing on more research and really investing on ACT training. Direction for the future research is that they should consider the inclusion of a larger sample. This was less than 100 people, which is half of the first article sample, and it would be interesting to see it on a larger scale for sure. Researchers ought to consider developing and testing the feasibility of online digital versions of the current intervention in order to increase accessibility and reach and to ensure easy roll out in a future pandemic. I didn't want to include this because I do find that it makes everyone's life easier. I do find that just by implementing this training on an organization and having it recorded and making sure that the staff do the training every year, for example, or every 2 years or something like that, it would already provide a great benefit. I do think that this could be expensive if we get ACT training all the time, continuously to everyone. But if we do have policies in an organization in which someone needs to do this training every year, for example, a 4-week training every year, 2 hours per week, and 8 hours in total, I think that would already have such a great impact. And just by using recorded trainings and maybe recycling these trainings every 5 years, I don't know, but maybe just by starting and using the virtual teams, that would be also great. I do think that there is a lot that could be exploited here in order to make this more accessible and feasible to smaller to larger organizations, to organizations that are further away, in locations that are remote locations, and that would maybe benefit a larger number of people. And very happy to see that both articles, they show basically the same thing. Mindfulness programs, including MT or ACT, they are great to decrease one's psychological distress, and to improve one's mental health and well-being in the healthcare worksite. Thank you very much for your time. Thank you, Lee, for being so patient with me. I appreciate it.